that's it. Go ahead, Mark.
Great, thanks a lot, Angie, and thanks for your participation in this film. It's I think most of us found it quite moving, just helping to identify some of the really difficult and challenging issues around the issues that people face that result in them seeking out psychiatric and mental health care, and also the incredible challenges for the doctors who are the ones we go to in these circumstances. So, I just find I've been at this for a long time. In law school, I worked in a halfway house for people coming out of acute psychiatric hospitals, and at that point in the early 1970s, we thought we had a lot of magic bullets for acute psychiatric issues, and I think over time we've seen some of the challenges those medications have created for individuals and for psychiatrists and psychologists as well. So I'd like to have each one of the panelists introduce themselves and say just a little about what they do, and we'll get to some questions afterwards, but let's go through some introductions first. So Dr. Isom, if you could start.
So hi, everyone. Thank you for offering me this platform to be here. I'm an early career psychiatrist working at a federally qualified health center in the Boston area, and I work at the intersection of community mental health and racial justice. I'm also a medical educator who works with trainees to address racial disparities in the mental health care system and talk about the impact of racism on any person's opportunity to achieve health and well-being. So very happy to be here and to learn from you all.
Laura, you want to go next?
Sure. Hi, everyone. I'm honored to be here. My name is Laura Delano, and I am the Executive Director of Inner Compass Initiative. We're a 501c3 charitable organization based here in the US, and our primary purpose is to help people make more informed choices about psychiatric drugs, diagnoses, and psychiatric drug withdrawal. I come to this work as a former patient. I took psychiatric drugs and had a whole slew of various diagnoses over about a decade and a half, my teens and 20s, and ended up having realization about 10 years ago that that wasn't where my answers lay. So I came off the meds, had a very hard time, as many of the subjects in the film had, and founded this organization to basically create a resource for people to get that information that I didn't have about how to come off of these drugs safely and about the risks of these drugs in the first place. So it's great to be here.
Okay. And Dan, go for it. You're next.
Thank you very much, Mark. My name is Daniel Fisher, and I'm Executive Director of the National Empowerment Center. I also am a psychiatrist, many years work in community psychiatry, and I use open dialogue to help families get through crises with minimal amounts of medication. And I have my own lived experience as a person who was labeled with schizophrenia and who was able to withdraw from medication. I liked Laura's description of informed choice. I'm not anti-medication, although because I think I feel people have a choice and medication should not be forced on people, I sometimes am described as anti-medication, but I'm not. I prescribe medication. I just think that people should know what they're taking and they should know how to get off it.
Thanks a lot. So, I'd like to start and just ask each one of the panelists for their takeaway from the film. I know that Laura Delano and Dan Fisher have both seen the movie before. So, Dr. Isom, I think this may be the first time you've seen this film, and of course you're out there practicing day in and day out. So, I'm really interested as to your takeaway from the film. And don't forget, people, to pop your questions into the question and answer box. I know we have some mental health professionals who are viewing this as well, as long as a whole bunch of attorneys who work on our panel. So feel free to ask questions. Dr. Isom?
Yeah, so I am an over-preparer. So I did ask to see it before the event. So this is actually I think the third time I've seen it. And I found it to be a powerful personal narrative description that we don't hear very often. Like I said, I'm an early career psychiatrist. I graduated residency last year. So I've been in practice for about a year now. And it's a reckoning experience to be actually in there in a clinical setting outside of training. And you know, it's not the kind of story that you are told in your exposures to psychopharmacology and what it means to prescribe. So I found it very refreshing. And I am, you know, situated in a community that's typically disempowered and marginalized. So the idea of informed consent, informed choice is attractive. It has been before watching the film and still is now. And I appreciated seeing that piece in there because that's a very empowering tool that you can offer any person, particularly patients in this kind of relationship.
Laura?
Yeah, I mean, I've seen this film a number of times at this point and am so happy it exists because I think this information has been out there for a long time about the effects that these drugs can have, especially when taken over the long term, about the difficulties in coming off of them, and yet it's almost no one knows this. And I think the fact that this film has now come into being and that it really raises up the personal narratives of people like Angie is so important, because I think change isn't going to happen just because the information is there, because as I said, it's been there. I think it's going to happen when people really connect at the heart level with other people's stories, and the film does that so well. And so I'm so glad it's out there. I'm so glad that all of the participants here have had the chance to see it, and I'm looking forward to hearing about people's responses.
Dan, what's your takeaway from the film?
Well, I'm really glad also that it's out there, that we need to have this information out, and it's my second time watching it. I'm very moved by the stories, and I agree with Laura, when you reach people's hearts, that's when people start to listen in a new way. And it's those personal stories that make a big difference. I also was struck by the idea of normal, which has come to mean comfortable, and the idea that people expect that they'll get medication. And it's a two-way street. Doctors are taught to give medication. We didn't hear, I'd like to have heard more about how consumers, people who are seeking relief, are inundated with the television ads. I mean, they did show some of the television ads, but it is such a systematic sort of barrage of misinformation. It was good that they pointed out that there is no basis to the chemical imbalance theory. It's just a theory, and it's really not a good theory. And it leaves people thinking that they take the medicine just to rebalance their chemistry. When I prescribe, I say, this won't solve your problem by itself. It may give you a little extra time, but it's up to you. And I was very lucky that I had a psychiatrist who helped me gradually get off medication and who always believed in me and my capacity. And I think that's very important. Last thing is Angie's description of the peer support, basically, in that retreat. Very important. And the peers, other people lived experience played a big role in my own recovery. And I think we need to have more opportunities for people to share with other people, as was shown in this movie. So thank you.
I have a question, which is it sort of taking the skeptical view of the film, does it oversimplify the issue? Aren't there some people who really benefit from the medications? And aren't there some people who may need to be on them for a lifetime? I mean, that's certainly what we're told. Angie?
I was the person.
Yeah, go ahead.
6 years ago, I would have said exactly what you just said, that meds saved my life, that I was completely committed to recovery. I went to my therapy appointments every week. I went to a psychiatrist once a month. I was convinced I needed the meds. I was told that I would be on meds for the rest of my life. I was also told I would never complete college. I was also told other things, I mean, that never were true. So I always just invite people to have an open mind that even people that you think should be on meds for life, they also have a chance for healing, that we should not just like label someone and throw them away. Like that's not okay. And also that your story can change. My story changed. The meds were helping me. I don't even think I consciously knew that I was going to come off of all of them. It was just like a harm reduction approach that I'd been taking over a decade, just slowly coming off things. I had tried over 47 psychiatric drugs in a 13-year period looking for the right combination, and they just didn't, they made me worse. I mean, I don't know. So I just think the story changes. It can help you one day, a year later, it could hurt you. You could become pregnant and want to come off of them. You could have a life-changing accident and you need something else. You know, things change. It shouldn't be a static story.
If I could jump in too to add that I think this is where the issue of withdrawal is especially important. I think this narrative that some people need meds even for the rest of their lives often comes from memories of people's past experiences trying to stop their meds. And because this information about slow tapering, as you saw Dave, elucidate so well with his hyperbolic curve, that information, even though lay people have known it for at least a decade, if not more, is not out there in the mainstream. Your average psychiatrist has no idea about it. Your average person certainly doesn't. And so people try to come off their meds for whatever reason. All hell breaks loose and the symptoms come back and they relapse. And then that just reinforces this idea of the person needing their meds. And I think that story has happened to so many, probably millions of people at this point, that it becomes the defining truth of what these drugs are. And I think that's why getting really informed about, first of all, the reality of physical drug dependence and psychiatric drug withdrawal, and then also about what it actually looks like to taper slowly and carefully, and how that experience can be totally different than what stopping abruptly can look like, is so important. I think that will help disrupt this idea that some people just need them indefinitely.
Yeah, I think that psychoeducation piece is really important, because people will come in and say, we'll talk about different experiences that they've had when they've missed doses of medication or had stopped taking it for whatever period of time, for whatever reason. And there's a diversity of reasons there. I mean, again, I work in a public mental health system. So sometimes there's a paperwork reason from the insurance company. Sometimes there's a financial reason. People can't afford to take the bus there or can't afford to pay for it. So disruptions in taking medication are pretty common, or more common than they should be. So there is a conversation that I have that was not taught in residency, but I have, because I've, exposed myself to other ways of thinking about this. And that is, does it mean that you feel X, Y, and Z way? It could be that there's a recurrence of whatever was going on before. It could be that you're responding to the removal of something from your body. So I think that piece is really important. And then there's a lot of diversity here in people's experiences, at least in my exposures to working with patients. There's lots of nuance there. People have lots of complicated relationships with their medication. And I think a real huge part of it, at least for me, has been figuring out what that relationship is. Are you taking it because someone's told you that you're supposed to take it? Are you taking it because you found it helpful to you for some reason? Is there something about taking it that you believe is harmful to you? Like, having that kind of open conversation, again, is something that, from exposure to people at Yale, like Swapnil Gupta, who's a fellow psychiatrist, Rebecca Miller, and John Cahill, these are the deprescribing book people, has allowed me to ask different questions in visits with patients that just opens up the door to other reasons for why someone might be having an experience based on difficulty taking their medication. So.
Yeah, I'd like to comment on this. I think that it may be that some people need medicine for a very lengthy time, but we don't know who that is. And if you, at the front end, predict that everyone with especially some severe condition have a permanent condition, that becomes self-fulfilling. And not only are people told that they have a permanent condition from which they'll never recover, which I think should be malpractice, actually. But they're also told, don't take a stressful job. Don't try to go back to school. Just try to stay on maintenance life. And that means you have no meaning. You have no purpose. And recovery is about finding purpose and finding meaning. So the very act of saying, you have a permanent condition from which you won't recover takes away the capacity to hope, the capacity to have friendships and have a meaningful job. And I think we understand now that recovery is an active process and that the person's own sense of self has to be engaged in order to recover. So it's very disempowering, though, to say, I know what's best for you. Open dialogue is a very good alternative approach. Very hard to get into this country. There's RAP planning developed by people with lived experience. We've, through our center, do something called emotional CPR. There are many alternatives. And that's the other real crime, is that people will routinely say, we've tried everything else. Oh, yeah? Have you really tried everything else? They mean they've tried another medication, maybe. Or maybe they've tried, ECT. They don't say, oh yeah, I tried a different kind of family approach. I tried holistic health. I tried acupuncture or something interpersonal. So we need to expand our view of what helps. And it's usually chosen by the person.
And I would also add, expand that menu of options to all people. Because again, it's not necessarily accessible to all patients who are making choices. So sometimes their only choice is a medication, and they may have a different regard for counseling or psychotherapy based on their own cultural experiences and backgrounds. So if that menu of options was available to all people, I also think we'd be having different conversations, especially in the public, sector, where options aren't as robust as they should be. But there are places like the CMHC in New Haven, that's a public place that does have access to more like recovery-oriented services. They're very focused on that there. But that has not been my experience in the current place I'm working within, which I think is more representative of that kind of CHC, community health center experience.
Well, I worked at, I don't know, I should have said this at the beginning, but I trained as an outpatient therapist and I worked in community mental health. And I mean, we had alternatives, even things like grief support groups or a mother group for newly Hispanic mothers that had just given birth. I mean, there was things. It might take the work of a social worker who spends more than like 8 minutes with a client to help dig those things up and like, what goals do you have? But I think we do a disservice when we say there's no other option than meds. There is. It's just being creative, working with the person's goals, finding things. I mean, I remember with one client, she wanted to plant a garden because they were living in poverty and didn't want to use the food pantry. And what's at the food pantry? Not anything fresh. So we found a seed exchange. She went and picked up seeds and planted her seeds and made a garden, and it brought the family together because they had the shared experience. So I think mental health is more than just, medication and going to your appointments on time. There's so many other things that has to do with it.
So for those of you who are now or have been practitioners of some sort, isn't one of the challenges we face now is essentially the time that's allotted to you to meet with your clients and speak with them so that you can actually engage in these other activities? Back in the day when I represented some doctors and some psychiatrists, one of their concerns was, I've only got 45 minutes if they've got that, and sometimes it's even less. So, how do you do that? How do you work that into your practice and still survive?
I can't really say because I didn't pick a job where I would only have 4 to 5 minutes. So
Good.
I said I work at the intersection of racial justice and mental health, and I can't do that in only 4 to 5 minutes. So where I work, I have 25 to 30 minutes for follow-ups, and then 60 minutes for a new evaluation. So there's more time in that visit to talk about the whole person. So I can't really speak to what a 4 to 5 minute visit would look like, but I've heard about those, and I know they exist, and they're, it's actually described as a 15-minute visit, and they can be very medication focused. So for example, some people function as psychopharmacologists, and there's a psychopharmacology clinic, and in that you have the 15-minute visits for people per hour, and you probably get a little bit of what people's life experiences are, but it's mostly focused on medication. So the structure is different depending on where you work, but I could not work there. So I chose a job that allowed a little bit more flexibility and has support from a pretty huge team of clinicians. But it's a important thing to point out that there is limited time. The funding structure of what people pay for is also very medication based. There's like a systemic aspect to this. So billing is influenced by whether or not, a part of your visit includes a medical action. And as a psychiatrist, that often includes a medication. So there's lots of pressures that people are experiencing that drives them out of the kind of sector that I work in into private practice, where they can have more time, have more flexibility, and make different choices.
That really is what happened to me. I worked 20 years in a public clinic, and we had productivity quotients. We had quotas, and we got a printout at the end of every month. Were we meeting 3 to 4 visits every hour? And it was financial. That was a long time ago, 10 years ago that I left. It was $50 for 15 minutes. And I said to the clinic, I want to do some therapy. I want to see some of these people in their context and their family or group. And they said, you have to do it on your own time. We don't get enough money for it. I do now work privately. I insist on half an hour at least, as a follow-up. But it also, I think, has to do with education. I'm really glad that you're educating residents, Jessica. I've had a devil of a time getting in to educate residents. They know how, my perspective. Most of the places do. Like UCLA, I thought, well, I'll try a different state. And I knew a guy on the faculty there, a wonderful person, Dan Dorman. He wrote Dante's Cure. It was a therapy, recovery without medication of somebody very severe condition. So I called him. I said, I'd like to teach, just when I come to California. And he was silent. I said, what's the matter? He said, they don't let him he's on the faculty. He said, they don't let me teach the residents. And he said, when he went to the head of the department said, we're in a controlled environment here. We program our residents, and we don't want them hearing what you would tell them. Literally. And I find that to be the case, even here with these great, Harvard teaching hospitals. So I want to talk to you, Jessica, and find out how you managed.
I'll say, I know, Laura, that you're going to speak, but I talk about a topic that they don't want to talk about either. So I can recognize what you're describing, and it does take a little bit of aggressive pushing to talk about topics that are not mainstream, but we could talk offline.
We'll talk offline. Yeah, sorry. Go ahead, Laura.
I was just going to chime in as a non-practitioner. I think this question begs a kind of a bigger question and a stepping back and asking, how is it that we're defining help in our society to begin with? And I think we do live in a society where we have largely professionalized help and come to equate legitimate help with going to an expert whom you usually pay. And I think in doing that, while there are, of course, many great helpers who are professionals, I think we have cut off a long, ancient history of human beings helping each other in almost like in an actual mutual aid capacity. And I think that's, the organization that I run, Intercompass Initiative, we're all lay people and we're proud of it. And really what we are encouraging is to help people find ways to help each other without needing to rely solely on professionals because of all these horrible limitations and managed care and all of the obstacles that Jessica and Dan both described so well. And I think this is especially true when it comes to withdrawal and for people who do want to come off, and to any practitioners, lawyers, advocates who might be listening. You know, it's as you saw in the film, it's a huge decision to come off of these drugs, and to do it right, to do it as safely as possible, as carefully as possible, it takes a lot of time. It takes a lot of resources. Of course, class, as has already been mentioned, is huge here. I think all the time about just how lucky I was that I was born into a family and into a life that provided me all kinds of privileges and resources and insulation so that I could spend literally years disabled in withdrawal and be taken care of. And I wouldn't have gotten through without it. And so I think when we're talking about people wanting help getting off of these drugs, currently the way the helping system is set up, it's not equipped to do it right. And I think, you know, that it makes it understandable that so many practitioners might be resistant to this idea of helping their patients come off. Because if you have 15 or lucky enough to have 30 an hour, 60 minutes with a patient, that's still not, it's a drop in the bucket when it comes to the time it takes to really be with a person, supporting them to get off of these drugs. And I think that's where the lay community becomes so important, because we have endless support groups, free resources, guides, manuals, all kinds of things. And so I think as we talk about these issues, it's important to make space too for that lay voice, which has a lot of wisdom to share and a lot of useful help to offer as well.
So I'm gonna mash together here, looking at the time, a couple of questions that are on in the questions and answers. So it basically focuses on what is, and Jessica, you may be the one at this point to really answer this, is what's being taught in med school now, or in the residency programs about informed consent and psychiatric medications. And then now that you're in practice, what do you do with the patient who comes in and, you know, I see these ads on TV and they say, well, they told me to go to my doctor and ask about whatever the medication is, and that's what they're really looking for. They're looking for the magic pill. How do you deal with that kind of an individual? Okay, I can.
Yeah, so for the first question, I think it's helpful to take a step back and think about informed consent for all medications, because medical school is focused on training doctors in general. And I'm just trying to remember, it wasn't that long ago, but it feels like it was. I think we had something on informed consent in medical school. In residency, a psychiatry residency, we were mostly focused on how do you responsibly prescribe? And there's like a psychopharmacology course, and we're taught to know, like, what's the medication name, what is it like FDA approved for, and then what are the side effects that you're, you know, supposed to offer the patient. And we role play. In my program, we role played that. And the experience of listing out the side effects is an interesting one, because it can be a very long list, and it's very hard to pick what to prioritize. You know, it probably should be a value-based conversation. So for example, you could ask a patient, you know, is weight gain important to you, or not gaining weight? But there's a long list for all medications. So Tylenol, ibuprofen, not any different, but there's a lot of focus on that in that psychopharmacology class for psychiatry. So then you get to sit with a patient. And the way that I approach this is probably information overload compared to how I was taught to do it. Because, and I'll say this, there's no expertise on what's the right informed consent. So this is my own judgment of calling it information overload. So I'll say, you know, we're going to start this medication if you're interested in it, and we have that conversation. So starting it, it's important for you to know that there are these side effects, and let's go through them. And then I try to make it not a doomsday conversation, because a part of listing a list is overwhelming for the patient too. And all of the potential benefits can get lost in the long list of side effects. And I say that because I work in a community health center, and I know in primary care, they start medications all the time for blood pressure, for diabetes, for a number of different things, and they have a different relationship with informed consent, but it's still our responsibility to do it. So I offer that information, and people's receipt of that varies. Some people don't want to hear all of that information and they say, just tell me what I should do. Other people have specific concerns from that list that they want to talk about. So that's one piece of it. And then there's like a selling aspect of prescribing. You know, we're told that these are helpful for what they are FDA approved for. And then there's a number of off-label indications that they're supposed to be helpful for. And I have tried to undersell them. Like, this could be helpful to you. It could not be helpful to you. I have no idea, actually. I can't predict the future, but we can kind of check in and see how things go along. So again, that's like a stylistic approach from just being exposed to other things. But it's really hard, I'll say, because you want to respect people's health literacy. You want to respect their like cultural way of relating with you as a health professional. So some people have a very like deferential regard for you as the doctor. So you involving them in decision making can feel like, what are you doing? Do you not know what you're doing? Kind of thing. So if we could have a class like dedicated to this, that was informed by these different perspectives, I think that would be the intervention, because most people are kind of piecing it together from traditional education and then what they happen to expose themselves to in other places. So that's my individual psychiatrist answer.
I think that's
trained a long time
Go ahead.
ago. So my training, it was in the 70s, and actually it was a Cambridge hospital. I had 6 supervisors for every form of therapy, and there was actually not a lot of attention paid to the medications. So I was sort of fortunate in that respect. And it seems like it's mostly doctors in my generation, psychiatrists in my generation, who really remember that psychiatric training used to involve learning to do therapy, individual therapy, family therapy, group therapy, all the different types of therapies. And I yearn for the time that, you know, that could occur again. I also think it's good that you were talking about role playing, but it sounded like it was more around how to inform people of their medications. I think basic communication, developing a relationship with your doctor is so vital to healing in any kind of medication. And they trust, if they trust you, then, and there is a trusting relationship, then you can make the adjustments that are needed. Because I took these very strong medications in my 20s, I knew what it was like to have dry mouth. That's not a minor thing, or to have restlessness, akathisia. You just can't sit down. Some people commit suicide because of that. And so I would say, notify me right away. We'll make a change. We'll make an adjustment, no matter what. And I would just give them my phone number. I don't care if I'm in the clinic or not in the clinic, because I know how vital that is. And the people working in the residential programs, they went apoplectic. Why are you changing these meds so much? But it gave power to the person who was taking it. And it's their body and it's their right, not only to know, but to make adjustments. Because as you were saying, Jessica, we don't know ahead of time. I mean, this helps some people. It might help you, might not help you. And they hate to hear that. Yeah, what a guy in the white coat should tell me. But yeah, I would say humility and entering in a not knowing relationship would be very helpful for doctors.
Well, looking at the questions, Angie, we have enough to probably keep us going for another hour, and some really excellent questions. So I don't necessarily want to keep the panelists longer than we asked them to come on, but one of the questions, or two of the questions, again, I'm going to mash them together, is really how do you deal or address the issue of medications and conceivably tapering medications with adolescents or younger, or people with developmental disabilities? So that's, of course, an hour-long or 2-hour lecture, or maybe an entire course to answer that. So if someone could give a shorter term. I don't know, Laura, if you've dealt with any of those issues with children or individuals with developmental disabilities.
Well, to the issue of children, I mean, I think I have strong opinions about psychiatric drugs and children. And, you know, yes, some of them are approved by the FDA for use in children, but you know, as we saw in the film, that doesn't necessarily mean that they're safe and effective. I mean, my general view is that it's wrong to prescribe drugs to children, but of course, the reality is many children are prescribed these drugs. And so the families I've worked with prior to this nonprofit, I worked as a consultant for 7 to 8 years with individuals and families who wanted to come off of their medications and get better informed and get support. And I did work with some families who had children under the age of 18. And it is, it's a complicated issue, because I think, speaking as someone who was medicated as a kid, you know, when you're a teenager or even a little younger, you know, your sense of self is forming. And so of course the drugs are going to interfere and affect that. But also once you have a relationship with these drugs, it can feel, it gets complicated when suddenly your parents maybe realize, uh-oh, these drugs aren't the things I thought they were, or let's get our kid off. If that child has an investment in the drug and a relationship with the drug, it can actually, you know, be another kind of misuse of power to have parents just step in and suddenly say, sorry, we're stopping you. So it's complicated. I don't think there's a clear answer, but I definitely think if this question is coming from lawyers, I think getting you as the lawyer, you know, getting really informed about A, if this drug is even approved for use in children, B, if it's approved for the specific uses that the child you're advocating for is being prescribed the drug. And, you know, if the answer is no to either of those, then, you know, there's a compelling case to make for coming up with a taper plan. But I don't think there's a clear-cut answer. And I do think, especially for older children who are perhaps invested in the meds, and which is so common, I think finding a way for them to be involved in the process, for them to feel like they have agency over their body and their choices is important too. And with developmental disabilities, I only have indirect experience just from family members who have family members with developmental disabilities. Of course, so many people with developmental disabilities are on potent psychiatric drugs. And, you know, I think it's really problematic, again, because of course these drugs aren't being prescribed because they're treating an illness. They're being prescribed for behavior control and management. And it really is for the benefit of the people around that person, usually often not the person themselves, that these drugs are prescribed. And so I think looking at that is a really important issue, and involving all the support system in the conversation to say, you know, what are the real reasons this person is on this drug? And could we come up with an alternative way to get them the support they need, so that you don't feel as their guardian that they need to, you know, you need to rely on this potent antipsychotic anymore to keep them calm or whatever it might be. But again, another messy issue. And I feel for anyone doing this work, because it's, yeah, very tough situation, both of them.
I see we've actually come. Go ahead, Daniel.
Just, when I was working at clinic, I would often have therapists come to me and say, this young person needs medication. And I was always very loath to give, you know, I mean, especially an antidepressant. In England, they say you can't give an antidepressant to a child under 18 because the potential for increased suicide is so high. But it was interesting because they'd come to me, the therapists come to me and say, you know, this young person is, you know, in great distress. How about medication? And I would just routinely say, I want to meet the family, and I want to know really what's going on with the family first. And they're like, but you're the psychiatrist. You're supposed to prescribe medication. But I've always had a family orientation. And now that I'm in private practice, I can use this approach in working with the whole family. In many, many instances, if you really have a good family approach, not the old kind of family approach that blame the parents, that was discredited, but this approach that's out of Finland called Open Dialogue. Doesn't blame anyone. It just says the problem is between people. And I've been able to work with people with quite complex, young people with quite complex problems. When the parents are willing, they're not blamed, but also the individual with the distress is not blamed. And in that context, in Finland, where they have it as a whole systemic approach, they've been able to get 85% recovery among people, young people, quite, in adolescence with first break psychosis. And it's a tragedy that we can't get it more readily into this country. And when I went to NIMH, talked to the director, it was Tom Insel at the time, and I showed him all the research. It's evidence-based practice from Finland. He said it's too different from what we do in the United States to bring it into the United States. It's so sensible, and it's so much more comprehensive.
And I'd just like to add one more thing, because it's important not to artificially flatten this, because the most vulnerable group to being exposed to psychiatric medication are Black and brown children and poor children, particularly those who are recipients of Medicaid. So whatever interventions we're thinking of, that would be the most vulnerable group that's prescribed the most medication that's not FDA approved. I'm not a child adolescent psychiatrist. It's an additional 2 years of training, so I don't see kids very often. Kudos to them for doing a very challenging job. But I just want to highlight that there's a unique vulnerability based on your social position to that relationship with psychiatric medication.
So in fact, we're going to be inviting Dr. Isom back to some of our trainings, because these are important issues, and there are a couple of issues that are particularly addressed to the BIPOC community, to advocating for themselves, and also I think recognizing that one of the challenges that community faces is simply getting access to the to treatment at all, or to services at all. I realized this the other day, that our division is really the only division who has a client base that wants to access the services that we're involved in many respects. In the criminal division, no one is really looking to get arrested by the police or go to jail or prison and charged with a crime. And we have sort of a different situation where people may, in fact, be wanting to get some help. I know I see it's 7 o'clock, and that's when we were scheduled to end. I did want to ask Angie one question, but I'm going to take the liberty of making a comment. This is my belief and my opinion, and as I mentioned in the beginning, I got first involved in mental health issues in 1972, spent 2.5 years in the halfway house for people coming out of acute psychiatric hospitals. And certainly at that point, I think people thought we had a lot of magic bullets that were going to save people. But what I learned there, in fact, was that dealing with individuals, what would now be called holistically, being there to talk to them, being there and able to work with them, also has substantial value. I like to think, since I had absolutely no training to do that I'm hoping we didn't hurt anyone in the way. When we were there, we lost some people along the way. And that was very unfortunate, obviously. But the other thing is, and it fits in with what Dr. Fisher just said, we do not have a system, and this is my opinion, this is not CPCS's opinion, we do not have a system that really supports the holistic approach to dealing with these issues, where the doctors can take the time, and there are other resources involving the family and looking at things. We had the one, Dr. Arndt, I think it was, from Stanford, and I know one of her colleagues out there has actually written a book called Lifestyle Psychiatry, which addresses all sorts of other things you can do besides prescribe someone medication. So I really think that's an issue, that's a policy issue that we need to look at. It's policy issues that we do address from time to time as a Massachusetts legislature when they talk about different ways to force people to take medication through assisted outpatient treatment or commitment, which we don't really have here. So anyway, I want to thank everyone. I do want to have, go ahead, Dan.
Final statement here. I'm not pushing a product, because we don't make money on this, but this is This is the result of about probably 30 or 40 people lived experience working over a 12-year period. What we most wanted when we were in crisis, when we were in distress. And we call it emotional CPR. And it's being taught now all over the world in 6 different languages. And people, people of color who don't want to see a psychiatrist are really respond well to people who are more authentic, and understandably so, I think, in a way. We don't say, you know, this is the only thing that you can do, but we give this to families to look at and to study between sessions, so people have something they can do and some way they can be. And it's really very simple. The C is for connecting at an emotional level. And that's not that simple, because you have to know something of your own feelings. But you need to share some of your own feelings when you're helping somebody, because they want people, you want somebody who's authentic. You want somebody who you can trust. And the P is for empowering. We feel that people should have a voice. They should express what they need. And the R, which results from this type of interaction, is revitalization, and people actually do feel more alive. And peers get it right away. Professionals have to unlearn what they've been taught, which is not to share and not to, you know, be authentic. We're not saying share your whole life or cry uncontrollably, but if someone has lost, you know, a loved one and you feel a tear, it's okay. If you're assisting them, it's not only okay, that might be the most important thing you can share with that person. I just wanted to, emotional CPR.
Yeah, there's a lot more information at actually the Empowerment Center's webpage there, and it's the same with Laura and Inner Compass. And what's the other group you work with, Laura, that you're the leader of? Oh, you're on mute. We made it. We made it almost 2 hours without having to say that.
Our main initiative is the Withdrawal Project, which is a comprehensive online hub of all freely available resources on safer psychiatric drug tapering. So we have a free step-by-step self-directed manual that helps people prepare for withdrawal and actually learn how to taper off, like actually how to do it safely. And we have networking platforms so that people who are looking to connect with others who want to come off medications or who want alternatives to the mental health system can actually find one another based on geographical location, interest, and need. And then we have a lot of information on the drugs, on the diagnoses, and all of that. And just one quick plug for all the lawyers out there. If you have not yet read Myers v. Alaska Psychiatric Institute, which was a Supreme Court case in Alaska in June 2006. Jim Gottstein was the lawyer representing the patient who was being forcibly drugged by the hospital. Please read it, because he won the case and he established a new precedent in Alaskan Supreme Court where now hospitals are required to provide less well, I guess the ruling was that they didn't provide this patient with less restrictive alternatives, and the hospital couldn't prove that these drugs were actually beneficial to the patient. It's a really important case. I know it's not national, but if you are wanting to get better informed about how to defend your patients against forced drugging, it's so important to read.
Thank you.
Zyprexa papers, right? Isn't it in that? His book is called Zyprexa papers. Yeah.
So quickly, if I can bring it back to Angie, who's one of the people in the movie here. You know, number one, I'm just so impressed with what you've done and your advocacy on behalf of patients and veterans in particular. So how did you get it, you know, just quickly, how did you get involved in this movie? How did they find you?
Well, amazingly, I was about 8 months off of the medication in severe withdrawal with akathisia, not leaving my home, counting my heartbeats, not to kill myself, like extreme levels of suffering. And they called me and they said, well, they found me on Facebook and in one of the support groups where I had actually been trying to help other people as a distraction to not focus on my own symptoms at the time. So they messaged me and said, would you like to be in this film? And I was like, no. And then she said, well, let me just call you and talk to you on the phone. And so I talked to one of the filmmakers. I was like, no, I'm not interested. Then she said, well, I want to come visit you. I don't know what she heard that she liked, but she came and visited me from New York. We took a walk. I could barely walk. I said, hey, I gotta, like, that's enough. I can't even, my nervous system was so upset, you know, from the withdrawal and everything. So she basically just talked me down. Like, she wore me down. And I said, okay, fine, I'll be in the film. But in a weird way, I think it really did save my life a little bit, because I kept thinking, well, now I have a reason to stay alive. Like, I have to tell this story, because I knew if I killed myself in that immense suffering that I was feeling, that the story that would have been told was she was just a veteran that was crazy from the war, and there would be this narrative, you know, and she'd be one of the 20 that died by suicide, and those darn veterans, you know, and I didn't want that to be my legacy, because I knew that that's not what was going on. What was going on was I was having a severe withdrawal effect from the way the doctor took me off the medication, from the long-term use of psychiatric drugs. So in a way, I'm glad to be a part of this, because my activism has been part of my healing.
That's great. Well, thank you all. Thank you all for participating. Thank you to Angie and everyone who shared in that movie. I mean, that is difficult to do, and at the same time, it's compelling. I think it's clear that these are extremely important and extremely complex issues. What I really liked about the movie, in particular, aside from the sharing, was that you didn't in any way, the film doesn't in any way minimize the difficulty in coming off the medications and the challenges confronting people who do that. I think all too often we may try and just simplify it and say, well, why don't they just stop? I have a long lecture on why don't they just stop, but it's 7:15 almost now. Thank you to everyone who is online. I'm sorry we didn't get to answer all of the questions. We will come back and have further discussions, because I do think these are important issues. Angie.
And I just want to say thank you for coming from the filmmakers. And our website, we have a reading list, we have resources, we have alternatives. We always like to say, don't believe anything you heard, don't believe anything we say, go read, start your own journey to critically think about the subjects. Also, we have YouTube with over 100 clips and other discussions like this one, and Facebook, Twitter, all kinds of articles posted. So we hope that this starts the beginning of a conversation.
Great. Thank you all. Thanks everyone for coming. Have a safe and hopefully do something enjoyable this long weekend. I was impressed too in the movie of seeing so many people wandering around in places not having to wear masks. It may be quite nostalgic for that time and hopefully we'll get to that again as we get through this crisis, because it is, as I've said on a couple of other shows that we've done or presentations we've done, for me, this is the most difficult time in my legal career that I've ever had to address. Just so challenging, and our cases just continue to go forward. There's been no abatement in people getting committed to psychiatric facilities, and I fear that it's going to increase as the pressure on people continues through this pandemic. So let's all hope and pray that we can get through this, and we'll see everybody on the other side without masks and not necessarily all virtually. So take care, have a good week, and again, thank you everyone.